Let me summarize where the MMS is on this issue. Our medical society first voted against physician-assisted suicide in 1999. This was in the chapter working here. At our interim meeting 10 months ago, we reaffirmed the position, which you have seen, which is now reproduced for you on the screen. The 24,000 physicians and medical students of the medical society believe we need to do more to contribute to the comfort and dignity of the terminally ill patient and the patient's family. We have rededicated ourselves to achieving that goal. I want to close with a brief comment about one of the arguments that is sometimes posed by supporters of this ballot. I didn't hear it tonight. This argument is that the issue is about the patient and that the physician's concerns are not relevant to the debate. They say that what matters are the patient's wishes and not concerns, not ours. Their concerns are not ours. This argument has validity, but only to a point. We do believe that the patient, we do believe in patient autonomy. We do believe that physicians serve the patient, with the patient's interests foremost. This is, after all, the most personal of all issues. But physicians should also stand by the ethics that have been the hallmark of our profession for thousands of years. Ultimately, it does come back to the Hippocratic Oath. While some elements of the oath are out of date, this section is particularly still meaningful. Above all, do no harm. There is good reason why this oath is recited by most medical students upon graduation. It evokes the core value of our profession. My concern is that if this question passes, this value will be undermined, and we will always regret the day that this happened. Thank you, and I look forward to our discussion and questions.
Great. I want to thank all four presenters for really wonderful descriptions of where they are and where they're coming from. And again, a few minutes for the back and forth. I have certainly thoughts and questions that have come to mind. I'm sure all of you do too. But David and Suzana, do you want to take a few minutes to comment what you've heard?
Well, where do we start? Yes, Suzana and I are both chomping at the bit. First of all, well, Suzana, being the gentleman, I'm gonna. Why don't you answer the issues related to that Dr. Aghababian brought up about his concerns about the short doctor-patient relationship in Oregon and that kind of thing.
All right. Well, actually, one of the things that I want to share is a part of this and a part of being a palliative care doc sitting on this panel is, from my standpoint, this does come from a place of compassion. And this does come from a place of selfishness, because this walking with somebody through even the discussion of the possibility of this is not something that I look forward to doing. And I often am sitting with people through their suffering and see opportunities for closure to occur. And I believe that allowing this discussion to happen actually might open the door for opportunities for healing and for compassion to be felt. Now, that being said, there are a few points that the Massachusetts Medical Society raised as concerns. One is, I think one thing that that I think you'd agree upon is there was a healthy debate, and that not every delegate at the Massachusetts Society voted in favor of upholding the previous policy. There were people who voted against it and who argued against it. So it wasn't a universal, agreed upon position. And I think some of the reasons why that were, for example, on the issue of physicians having a good relationship, if they've only known a patient for 12 months or less. I often only called in to get to know patients near the end of life. And I look around this room and I see medical students who've worked with me and physicians who've worked with me and others who've known me. And I think that the relationship that I have with those patients is incredibly close. And often I know parts of their lives because of the time that I take that others haven't known in taking care of them over a long period of time. So length of relationship from an insurance standpoint doesn't necessarily reflect the intensity or the quality of the doctor-patient relationship. The second piece is around the notion around how bad we are at prognosticating. I often talk on this issue, and I often refer to the work by Nicholas Christakis, who was referred to here. And there are a couple major points that I think need to be raised and clarified with this. One is that the prognostication of patients who are in hospice, for the patients who generally outlive their hospice diagnosis, tend to have diagnoses like dementia, or diagnoses that they won't necessarily, even from the beginning, have access to this law. On the other hand, patients who have serious illnesses that are terminal and rapidly progressive, like cancer, generally speaking, the same researcher has shown that if doctors say the patient's going to live 4 months, on average they live 2 weeks. So the prognostication piece in terms of how bad we are tends to be overly optimistic rather than overly pessimistic.
If I could just interject, virtually every study that's been done on this, Christakis is only one, has shown the same thing. If we have a side on which we err, it's in being overly optimistic.
So, this concern about us being bad prognosticators is really a non-issue from the 6-month perspective. And then the third piece in terms of, that I want to emphasize is that in the Oregon experience, the majority of these patients who access the law were getting some of the best palliative care and hospice care available in the country. Oregon and Washington have both been rated as providing some of the top-notch palliative care and hospice care in the country, and over 90% of patients who actually ended up requesting this medication and requesting this process were already on hospice or receiving palliative care. So I just want to clarify those 3 points.
Yeah, and that number, that percentage is actually going up every year. On the 15-year average has been 89% patients getting death with dignity meds have been hospice patients, and in 2011 it was 96.7. So, and that's been a steady
I think
trend.
Dick wants to
Yeah,
say a good point on that.
I think we should have it back and forth.
No, just let me talk.
Some things don't change. We are good friends, I assure you. Great deal of respect. His knowledge of kidneys. I'm going to address 3 things that Susan brought up and Dave embellished. One is the characteristics of a physician who is involved in patients who die. Number 2, the prognostic issue. If I can remember to get to it, the third thing was something to do with the Oregon experience with Mayor Worcester on my mind. Well, this is, many of you are medical students, perhaps there are some residents here. You should be looking for mentors with regard to end of life who are experienced clinicians who have demonstrated their mastery of the care of the dying patient and their families with dignity, and who respect that at some point therapy is no longer necessary, and who wish to teach this. The characteristics and skills of a physician who has mastered the care of the terminally ill patient include possession of medical knowledge about the natural course of the disease and how we at this time can intercede, and when it's no longer based on evidence-based medicine, time to go on. Number 2, understands how to relieve pain and physical suffering. And sometimes that means knowing, respecting the cultural and religious beliefs of the patient they're treating. Ability to practice patient and family-focused care. And that often involves interdisciplinary care involving many people in the healthcare profession. And lastly, for the ones I'm going to focus on, excellent interpersonal and communication skills that reflect a high degree of professionalism, and that the patient, they're willing to align the treatment, as I mentioned, with the patient's need at that time, and consider the patient's wishes. On the issue of determining death at 6 months, 7.5 years ago, actually more, I was diagnosed with a stage 4 adenocarcinoma of the esophagogastric junction. My excellent doctors here, and one who had been here and went to the Brigham, have kept me alive 7.5 years, and I would argue that for the last 7 years at least I've been doing something productive. I was also moved, my wife and I were moved, that Vicki Kennedy wrote a very nice letter in the Cape Cod Times over the weekend about her husband, Teddy Kennedy, who had astrocytoma, a very aggressive brain tumor, and was given 6 months to live. but in the more than 18 months he survived from the time of diagnosis, he ushered in a new healthcare bill. He helped elect the current president and influenced quite a bit of legislation in the Senate. So I think that was a productive 18 months after his initial prognosis. So I think we have to be careful when we say it's easy to predict. Sure, it is in 2 weeks, maybe in a month period of time as you see organ deterioration begin. I forgot the third point, so I'll stop there, Susan.
Yeah, I think, first of all, it's, what can I say other than that I'm, having known you for 30 years, I'm so happy that you're here.
Thank you, David. I feel the same about you. I feel the same about you.
We all know instances of people who have kind of defied medical odds. But let's use judgment here. People who are electing to go this route and feel that they are so limited and faced with nothing but further loss of function, who have espoused that they can no longer do the things that give meaning to their life. Those are the people who are receiving physician-assisted death medications, and there's just no arguing with the Oregon data about that. And by the way, the Washington data, although it's only about 3 years of complete data, say the same thing. It just keeps coming. And I even looked, by the way, I looked into what happened before Washington and Oregon back in the mid and early 90s when this type of thing was going on between physicians and patients on a more covert level. And the same, anonymous questionnaires, so 2 big, good-looking surveys, identified the same main reasons for why people sought to end their life this way. Not pain, but again, just limitation, inability to do the activities, loss of dignity, however we define it. That's our right to define it however we want, but it is only up to the patient, I would lean in this situation, to define it. His or hers is the only definition that really counts. As long as I have the mic.
I'll give you guys the mic for another minute or two, but I do want the audience to have a chance. Yeah, Phil's gonna get a chance too. But
Right, I'll be quick about this. The 5 patients who regained consciousness after taking the drug, that was, I don't know if you noticed on the data, but that was 5 out of 596 who took the drugs. That's a very small number. And were they any worse off than they were before they regained consciousness? Maybe they were disappointed or disillusioned. But
It's unbelievable.
They woke up and they all died of their illness within a period of days anyway. And I don't know, I haven't seen data about how many of them asked for a second go around. But the fact is that the regurgitations, by the way, some of these occurred before they knew to dissolve the CBNL, when patients were taking large numbers of capsules. So it seems, for the most part, like it's a lot more, percentage-wise, it's a lot more effective at achieving its endpoint and less fraught with unwanted outcomes than many of the other things we do.
Bill, I'll let you get the last word here before we open things up a little.
I just had a question or a comment about this, the idea that the ability to discuss this possibility opens doors, and I wonder what's on the other side of the door. Is there a slippery slope that's going to bring us somewhere we don't want to be? Tom Beecham, another one of my teachers, years ago wrote a paper that, and he argued, and I think he's still on this side, that he's on the pro side here. But he argued that even though he thought that physician-assisted, I think he was actually writing about euthanasia then, even though that might be ethically justified, he said it should not be a matter of public policy because he was afraid of slippery slopes. And I wonder, we looked at the data from Oregon there, that it's going up. Is that simply a reflection of more people aware and getting better care, or is that the slippery slope that's going to lead to euthanasia or whatever? And I think we've seen in the Netherlands a slippery slope where the euthanasia there is highly regulated, and there have been cases of involuntary, that is, people being euthanized against their own requests. So, you're worried about a slippery slope at all?
So I'm going to take the moderator's prerogative to ask the first question, and then we'll open it up some. So Dick, this is for you because, well, I've got some tough ones for the other side too. I was working on this, and so, but no, you very nicely put up what your advance directive is. Did you have to go see a psychiatrist before you were allowed to write that advance directive to say whether you want to be kept alive or not?
Well, thank you very much for asking that question. No, because we were both healthy when we wrote our will. But I want to answer the question.
Okay. My question, but that's
no, you make a very good point. There were several times after I was diagnosed with terminal cancer that I was very depressed. And if this had been an offer, I don't think I would pick suicide, but it's certainly something that passes through your mind. And I would bet if I felt that way, that I'm sure many people in the same position do. What's interesting is they've interviewed people who jumped off the Golden Gate Bridge. In fact, one spoke in Massachusetts just recently. And most of them are very remorseful about trying to commit suicide that way. Of course, they have to go through agony afterward to read, after hitting the water at 100 miles an hour. But if you look at people who were unsuccessful, and I certainly saw that in the emergency room for years, they were often remorseful about it. So the depression of having a terminal diagnosis is real. I saw my primary care physician, who I would hope in this case was sufficient. He would have told me if I needed to see a psychiatrist.
So
my primary care home.
where I was going with that is if you at a time when death is distant and you're healthy, are allowed to make a decision about wanting to die, why is it that when you're close to death and you know what it's about and you've got a better idea of what's really happening, we're now saying you're not allowed to make that decision? Because you're allowed to make a decision that I don't want to be kept alive, which is a tantamount to saying, let me die. If you're taking away a ventilator, that's an act that's just as much an act as giving second off.
This is a problem with this bill, and I'm going to highlight it, then I'm going to come back and ask you a question. Marcia Angel, so you gave me the door.
That's right.
In her article in the Boston Globe, on the op-ed, September 25th, she used 4 definitions of what the bill was. You actually have done a very nice job of highlighting them. Death with Dignity Act, the Self-Determination when Dying Law, the Physician-Assisted Suicide Law, Physician-Assisted Suicide. It's not the concept of controlling the end of death that I object, and some of the members, as is even pointed out, of the Medical Society, not everyone, but it's the fact this law is very confusing and fraught with error that we will later have to correct if we can. Now, what was your first question?
You've tried. Actually, I do want, because I want that stuff, and I think the audience wants to ask questions too. But there's been a lot, Dave and Suzanne, about the way the law is written. And in fact, there were questions that were given to us ahead of time, and again, the list was quite long, and the vast majority of the questions were, what about the clarity of the law? There's a lot of stuff, there are some loopholes, there's some inconsistencies, there's the fact that you don't have to see a psychiatrist or psychologist. There's a lot of questions about the clarity of the law, so would you like to address that?
Could you also compare it to the Oregon law?
Yeah, first of all,
Compare it to the questions, could you compare it to the Oregon law?
it's virtually identical to the Oregon law. Yeah. In terms of the I know this has been a concern of, that Richard has articulated about the fact that only 7% of people in Oregon have been sent to psychiatrists. But when, this is an informed consent process. Physicians are taught how to recognize the capacity to make and enunciate a medical decision. How often does it get so difficult that the patient's primary physician doesn't understand that or finds it ambiguous? 7% sounds like about a reasonable number to me. So that particular part doesn't bother me. The legal aspects, the idea that only one of the witnesses to the document has to be ascertained not to stand to benefit, financially or otherwise from the patient's death. Same thing has been going on in Oregon. That's the standard that they have used, and it's been successful there. As far as I think the bill pretty clearly says that the major offenses that we would worry about, which would be forging a request for physician-assisted death, burying a rescission request for physician-assisted death, or just coercing a request. It says those are punishable by civil and criminal. They are going to be handled as civil and criminal offenses, and that means that if we're concerned about that in a case, we get to call the cops, and that's who enforces this. This is a ballot initiative, and this is something people have to walk into a voting booth and read, and then decide if they're going to do or not. Now, you could argue that maybe such a weighty issue as this shouldn't have been handled as a ballot initiative, but there it is. And that's the form that ballot initiatives take. They're not going to go into absolutely every possible ramification, and whether it's the assistant under associate DA for Middlesex County who's going to do this. I'm not going to find that here. But again, same language as the original Oregon bill.
Just a couple of things too, is in the years in, I think this is working, in the years in Oregon, that as you heard is virtually the same bill here. There haven't been any documented cases of abuse or people falling through essentially 16 different safeguards. There are numerous safeguards in this bill, which makes it sound really complicated, but really it is the process that you've heard. A patient has to ask. They have to be able to ask. They have to have capacity. And capacity includes the assessment of, is this due to major depression, in which case they're not eligible for it. So that's part of the assessment. And how many second-year med students here have heard the lecture on how to determine what depression is? So, knowing that is something that every physician knows how to assess. And so the psychiatry thing is really when there's something in question. So there are all these numerous safeguards, which makes the law sound complicated, but the process really isn't as difficult as it otherwise sounds. The complexity of it is about the safeguards, which is what the concern is, and that has been proven not to be an issue in 15 years of Oregon.
So let's open it up right here. Question.
There's no requirement once the patient receives the medicine for a time frame in which for him to take it. Should there be a time frame for the process to start over again? And if the patient dies without taking the pills, should there be a requirement to return the pills to the pharmacy?
There is a requirement that there is actually a law in place already in Massachusetts that clarifies exactly what happens with unused medications for patients who die in one setting. So the answer in terms of the medication use, that's already addressed in existing law and would pertain to these patients already. So no change there. Patients die with numerous opioids at home, on hospice all the time, and there's a process of disposal, and there's a legal venue for that that will apply in this setting just like in any other setting.
The second, the other part, I'm sorry, you're going to address it.
That's exactly, the other part of your question was, should there be, I guess, kind of a term or a statute of limitation on how long the original consent lasts? We know from the Oregon data that, plenty of patients don't take the drug within the first year of getting it. And those that survive, whatever period of time until they get into the next calendar year, may wind up taking it in the calendar year after the one in which it was prescribed. Should people have to go through the process again as a kind of a test of the authenticity or the durability of their intentions to die? I guess, some people might argue that. I would say if the person wants to do it, still, that's good enough for me.
So one of the provisions in the safeguards is that the patient has to physically be able to consume the slurry themselves. So if someone declines to the point where they functionally no longer can swallow this themselves and have control over that process, then they no longer are going to have access to the medication. And that's part of the process.
May I just point out something? I don't think there's anything specified in the law that says Seconal, which is what they use in Oregon, would be the drug used in Massachusetts. So that is one of the many technical issues about this. It's interesting, you know, we have ballot question 3 on marijuana, the medical use of marijuana. If people want to legalize marijuana as we have alcohol legalized, that's fine, but calling it a medical issue is a whole different matter. Here we're talking about people who want to end their life. There are ways to achieve end of life without committing suicide. So I just want to make that clear. This is not all or none. And Dave made the question, but this has been very successful in Oregon. I haven't read anywhere, I've read the data, but I haven't read anyone come up with a scientific conclusion based on data that this has been successful. It has been implemented, yes, but I don't know how you would define success.
Go ahead.
There are so many issues we could cover, and I don't want to get into too many, but there's one thing that came up already that Dr. O'Brien brought up, and that Father Stempsey, is that right? Tried to object to, and I just want to bring it back up because I think it has bearing on both sides, and that is, as it stands, physicians are already allowed to remove care. We can remove feeding tubes, we can remove breathing tubes. To starve someone to death is an active process. By removing the tube, you have to physically pull it out. It is a painful process and a torturous process. To remove a breathing tube is to suffocate them, and that is awfully frightening. And that says to me two things. First, our current rules about death and physician-assisted suicide not covering the basis properly, should we go back and remove that ability? Is it still an active process? And for the other side, does this mean that we should be looking at ways to decide what people's needs are in advance and expand what this law already offers?
You're talking about the difference between killing and letting die here, and I certainly wholeheartedly would endorse the view that people sometimes rightly refuse treatment. Right? If you want to be on the side of life, that doesn't mean you have to do everything you could possibly do to prolong life as long as possible.
But there's a difference between starting the process and taking it out.
Well, yeah, philosophers will debate about that. I still do think that there is a difference between killing and letting die. And it has to do with what your intention. And I think when physicians start to act with the intention of bringing about death, it just
What other
is a
intention
different
could you
thing.
possibly have when you remove a feeding tube?
I'll tell you. Your intention is to remove a treatment that has become burdensome. When the treatment has become more burdensome, then we'll continue life.
Great question. There's let me just try to some of the issues you touched upon were things that I dealt with many times in my days of working with the ethics committee here. First of all, it's less common to actually remove a feeding tube than it is to just stop putting stuff into it, or than it is to not put it in the first place. One of the alternatives to physician-assisted death that has been suggested, there have actually been a couple of them, and I won't put use of advanced directives in that because I don't think that they really apply at all. But I think the things are voluntary cessation of eating and drinking. Okay. Terminal sedation, which is essentially putting the patient into a coma if that's the only thing that will keep them from feeling pain. Or short of that, just giving the most aggressive doses of narcotics possible even understanding there's a risk of unintentional death, but whatever it takes. Anyway, as far as the issue about starvation, dehydration, now this is counterintuitive, and particularly if you've not had experience dealing with the terminally ill, but there's now been a lot of study. I have a folder that thick of articles, prospective good control studies that have looked at deprivation of food and fluids at the end of life. And it's not inhumane. The patients, the conscious patients, they don't want it. That's the point. They do not want the very sustenance that you want. Their body is shutting down. Their mind is operating on endorphins, and forcing fluid and nutrition upon them enhances their discomfort. There's been plenty of data to suggest that. So I just throw this out, because I think it's important for people to understand that. But I also don't think that, again, that's not what this particular bill is about. As Dr. Stempsey points out, there's certainly a medical difference now between letting die by removal of life support and physician-assisted death.
And I'll add to that. One of the things that I do is I'm on the board of an organization called Compassionate Care ALS, and they take care of patients with Lou Gehrig's disease or ALS. And I got a call from a family of a man who had this ballot been law, he would have partaken in this. He had a terminal life-limiting illness, ALS. He knew what the outcome was going to be, and he didn't want to have the prolonged dying process that this disease would guarantee him. And given the restrictions of not having this in place, the choice that this gentleman had was to stop eating and drinking before his body fully started shutting down. And he lived for months in a state of starvation, and for him it was discomfort and agony, and it was taking longer. And the only recourse he had legally, at least is what he thought, was to deny himself these sources of nutrition. That I don't know how much it was helping, but certainly I don't know how much it added to his suffering, the lack of food or drink in this situation, but it didn't help him with the process, and it didn't help him with the goals that he had in place. He made that choice, and he wanted to find a different way of taking care of himself. Is that what all the patients I take care of with ALS want? Absolutely not. But this was his wish, and to give them that choice. I think your question is a really good one, and the idea of expanding and giving people an option and defining that choice is really critical. This is about the patient, and it's about our role as physicians of being an advocate, fierce advocate for a patient's will when they are dying. It's not a life or death decision. It's about allowing people who are dying to choose how they will die.
Yeah, that's you.
I was wondering if we look at this from a different angle, like as if we think about the government restricting our access to drugs as something that is a social construct as opposed to something that...
That sounds like ballot initiative number 3.
and looking at doctors not necessarily as giving drugs to kill someone, but instead restricting people's access to drugs that kill people until it's like appropriately. So instead of telling them when to die, we're making sure they don't use these drugs until it's not up to us anymore to make that decision for them. I'm just wondering if that's one way to look at it. Instead of killing them, we're stopping them from hurting themselves until we don't feel like we can make that decision for them.
Yeah.
I just went back and looked at the Oregon data, and in 14 years, there were 44 ALS patients who chose to ask for a prescription for suicide. 14 years. Read the bill carefully. And David is right, there's going to be criminal charges. We don't know what they are, who's going to enforce them, other than the physician. and we're going to create a huge bureaucracy to care for these patients. I want you to, it's not the concept of leaving people without dignity and care at the end of life. It's do we want to have it happen through a law that has flaws? That is the issue that you consider. Don't get sucked into just the compassionate part of it. We all are going to be compassionate, want to be compassionate with our patients. Look at how this law is structured and how is this going to be implemented in the state of Massachusetts. I would argue that the Oregon law has occurred, but I would not apply the term success to it.
There's a question back there, sorry.
I have two quick questions. First, about data, Oregon data. I have the understanding, maybe I'm wrong, that when you fill a death certificate of someone who gets these pills, you can never put cause of death as prescribed drug. You need to put like leukemia, the cause of death, you prescribe it. So how do you gather this data and how do you know rate of success and rate of like how many people die because of this? And how that make you or us feel as physician of how truthful do we need to do our documentation? That's number one. But let me just go for question number two. One thing that worries me about this law a little bit is like there's like healthcare costs associated. I know that most of us will spend most of our health insurance during our last 6 months of life. And how does that make you guys feel in the panel? Like if I will, in my last 6 months, will want to pursue a last round of chemotherapy or a last something, do you think if this gets approved, it's going to be a chance that maybe health insurance will say, look, that's too much. Maybe go for this option that is much more better for me in terms of health costs?
Great questions. First of all, about the Oregon, and I'm going to forget the second one because that's what's it. But regarding the Oregon data, those the Department of Public Health collects the forms, the paperwork that this process generates, so they get information that way. They also get information by direct physician report, and periodically you will see holes in the data where it says, such and such, we're not really sure what happened after that point. They didn't take the drug in 2009. We're not sure what, when it was prescribed. We lost them to follow up. So a lot of it depends on self-report. But because it is a process that is supervised by the State Department of Public Health, by the way, to access these data, you just go to the State of Oregon Department of Public Health, and it's right there. So,
we need to put the different cause of death, or
yeah.
how do we record?
Well, yes, you did have. Just so you know, the cause of the reason we know why patients are dying primarily of ingesting the medications is because we know the time of death relative to when they took the medication. But that said, our bill, and I believe this is true of the Oregon one too, stipulates that on the death certificate, the underlying disease will be listed as the primary cause of death. And I think most people would want that. And then, what was your other one again?
So the insurance piece.
Oh, insurance, yeah. But yeah, just, and this is something probably everyone ought to weigh in on, but Dr. O'Sullivan mentioned the medical principle of distributive justice or societal justice, which is basically that we ought to be distributing resources like medical care and expensive and scarce resources according to the maximum number of people that it can benefit. And that's something that's why we all learn about cost containment and practicing economic medicine. And why we hear candidates rail about medical waste on the rise. But all that said, when you're actually talking to a given patient at the bedside and you're making decisions on an individual patient, we never ever bring that up because, for obvious reasons, I don't think anyone would want to know that the bed that Aunt Lucy is in could be better occupied by kicking her out of the ICU and putting in someone else who has a better chance of recovery.
So to answer that second point too, I don't know if any of you have seen How to Die in Oregon, but they did highlight one of these cases, and this is actually one of the arguments that the people who are against the law have highlighted. And they talked about a man who was, who seemed to be a little bit disenfranchised, and he got a letter from an insurance company when he had advanced metastatic disease, saying, you know, we're no longer going to approve for further chemotherapy for you. Here are your 5 palliative care options, and then the last option beneath that is death with dignity. And he was so furious because he's a medical maximalist. You know, he wants everything possibly done to the very end. So he went to his doctor and said, can you believe this? And they appealed it, and he got his chemotherapy and died 2 weeks after his last dose of chemo. But the process is, this exists already where aggressive therapies are denied. And we as physicians, if that's part of the goal of care of the individual, is to continue to go back and advocate for patients. And that won't change with this law. So that's always going to be a headache of ours, whether or not this ballot passes.
I'm not in disagreement with Susan on this, but I want you to know that 12 years ago or 13 years ago, John Kitzhaber, the governor of Oregon, who's been reelected to be governor and is currently governor, and a physician, introduced the concept of rationing healthcare. And we had a list of diagnoses that would be treated and those that would not. So the concept of rationing care is not new and has been part of the Oregon culture at least 13 years. Brian, you might want to comment.
Well, that's true, and there are issues with it because initially capping teeth was rated higher than doing an appendectomy, which, you know, when you talk about cost savings over capping thousands of kids' teeth versus doing an appendectomy, the dollars worked out, but in fact, obviously, if you've got an appendectomy versus a toothache, it's a little more important to get your appendectomy taken care of. So there's lots of issues that go on there, and rationing is a huge issue, and it's something that's going to have to be addressed. Yes.
Thank you for letting me speak. I totally agree with Dr. Aghababian. I was just driving from Walpole, and all that I was speaking was the pros and cons. And whatever Dr. Aghababian said, I agree with you 100%. But the only one thing I want to say about the other opposition is, we said the family has no time for the dying elderly person. The elderly person has given life to us when we were small. They did everything from A to Z up to 3-4 years or all the life. And how come at this time that you cannot spend any time?
So I agree with you, and this depends on the particular individual choice and family and personal culture. There are patients who don't want that, to place that on their children. And there are other cultures where it's part of the cultural value. And so this piece is not to pass judgment on any particular cultural value or wish, but to recognize that for each individual, for each patient, when they face this time in their life, and as they're nearing death, that they have a choice on how to engage their family or how to make a decision at that time. So I agree with you absolutely.
Yeah, because it's the end of life. I think sometimes we as parents cannot sleep when something is happening to our own child. And when the person is dying, I think they feel, even though they may say, go and take care of your own life, but I think they will be peaceful dying seeing us. The kids are out there.
And in here, so again, it's about the patient's choice and the family to support them, and us as doctors to also hopefully support the patient.
And also you said that we as PCP spend less time with the patients than you as palliative care.
Not necessarily, no. All I'm saying is that the quality of the physician-patient relationship can't be defined by how long, necessarily by the longitudinal time that someone has been assigned to that doctor. That, as you know, even as a primary care doc, you can get to know a person very quickly within a few months. And that doesn't mean that the quality of the doctor-patient relationship is any less than someone who you've seen once a year for their annual over 5 or 10 years. So sometimes if you see someone monthly for that period of time as a primary care doc or anyone, and that's, I'm not saying this is specialty specific, but what I'm saying is the time and number of years that someone has had you listed as a doctor doesn't necessarily correlate with the quality of that relationship. And it can be from a primary care doc, an oncologist, a nephrologist, or anyone involved. So I agree.
I think we have time for one last question. people are certainly welcome to stick around and talk. I don't know what the time frame is for our speakers, but it's past 7:30, so I do want just one last question.
I think there's 6 months to go.
ahead,
Dr. Makowski, Dr. Clive, I hear you guys both talking a lot about compassion, especially in the face of imperfect sciences. We're all aware that medicine is not perfect. And I hear you saying that this initiative would be a choice for patients when the medicine that we have currently has failed them. My question for you is that in the years that come, while this is still on the books, medicine will see advancements, and palliative care will get better. So my question to you is, do you see this as a permanent choice that you would like to stay forever for patients who are currently going through hospice care? Or do you see this as a solution for the medicine that we have now, but will hopefully be phased out in the future as hospice care becomes better and better?
So again, I don't know. And again, I think part of it is that prognosis will change, is just like it has over time based on the advances of medical care. And the ability for us to alleviate suffering will change. And what I've seen with patients is when they say, I'm suffering so much that I want help in dying, what I've heard from patients in the past is that they said other people have closed the door to that discussion. And what I've done is say, because they say it's illegal, and this is coming back to your question, what I've done in that situation is tell me about your suffering, and tell me about your fears, and let's see what we can do to help alleviate and address those things. I think that conversation will never change, and I really believe that giving permission for people to have this conversation is one of the strengths of this ballot. It doesn't mean that it's going to happen, and people will follow through. And as the ability to alleviate suffering improves, the time that people choose to take the medication or choose to ask about this medication will shift over time. Whether it disappears entirely, boy, that would be a dream. But I don't see that happening in the near future.
And upstream from that, before we even get to improvements in palliative care, improvements in disease-modifying or curative care are going to occur. And so patients just, it keeps coming back to choice. It's the patient's choice, and they're just not going to choose it until unless they get to a point where they. And if I could just end my comments with one anecdote of my own, I've been sort of obsessing over this bill for a while, and this morning I was sitting at my computer just reading some stuff on the internet, and my brother came in. Now my brother lives at my house about 3 days out of every week because he's got myeloma, and he comes to Boston for his medical care. And for those of you who don't know, myeloma is an incurable, basically fatal blood cancer. Mike's been fighting it for about 8 years now. And he's a fabulous guy. He walks with difficulty because it does affect the bones in his legs, but he gets around, and he's very active, very productive, and I think he would tell you he has a good quality of life. And he comes to Boston for his chemo, many days out of the month. So today I asked him, just because he happened to stroll in, how do you feel about physician-assisted suicide? And he said, well, I don't need it, but I would like to know it's there if I choose someday to go that route.
All right, last word goes to Father Stempsey.
I don't know if you've seen the TV ad recently for a children's hospital in Boston. It's till every child is well. And every time I hear that, I say to myself, it ain't going to happen. And it's long been said, medicine is the only profession that labors incessantly to eliminate the cost for its own existence. That ain't going to happen either. I guess what I call for is a recognition of that. And maybe I wrote a paper some years ago about people talk about wise doctors all the time. I think we need to look for wise patients as well. When we talk about jumping all of a sudden to making choices based on our personal inclinations, I'm not sure that's real wisdom, which comes only with a lot of time and thought. So as the philosopher here, I guess I'm a lover of wisdom. I'm not really advocating some deeper thought.
Well, thank you very much.
Put up your bag.
Thank you.
Following Dr. Vippa.
Oh, no, don't think that. It's 50 pounds. It'll break your back. Don't worry about it. I'll get it.
Next question.
Here, I'll just throw that out. Oh, there's the trash can right there.
So, we'll see you when we see you.
You leaving? I think so. I don't know. Not gonna say goodbye to her?
Oh, Ian, thanks for that.
Studying properly.